before the recording starts. So no more swearing, okay? Because now I'm recording. Yeah, so now I did this comprehensive review, and now we're moving into talking about the formative function, which is the second function of clinical supervision. The first being restorative, second formative, and then lastly normative. All right, so what are competencies? So this is just one way to look at the idea of competencies. And it's pretty common in the literature. And you might hear the term KSAs, or knowledge, skills, and attitudes. For some reason, the literature often says knowledge, skills, and abilities. And for the life of me, I could not figure out what the difference between an ability and a skill is. And somebody told me that an ability is like more innate, like you're born with it. But how that helps us in this sense, I don't know. But I do know what attitudes are. And I can appreciate that you can have attitudinal competencies. In other words, you got to believe in recovery if you do this kind of work, or you're going to be in trouble. And so the other important thing about the idea of knowledge, skills, and attitudes is ideally we want to operationalize them so we can see them and measure them if at all possible. And it's not always possible. But and then if we can, that can be one of the important aspects of clinical supervision, is giving feedback on these knowledge, skills, and attitudes. And of course, if you're evaluating somebody's clinical performance, then it is a function of measuring and giving feedback on those KSAs. I don't know if you can, well, I think you probably can see this KSA down here, and it looks like some kind of weird blob for $10,000. What country is that? Dun, dun. Here, put it in the chat if you would. What country is in the bottom right-hand corner? KSA. Dun, dun. Oh, Saudi. That's good. That's good. Australia. Nice guess. Well, Saudi is really close, but what's the full name? Dun, dun. I can sit here all day. All day. All right, I'll just tell you. There it is. Nicely done. Kingdom of Saudi Arabia. That's right. It literally has nothing to do with what we're talking about, but I just found that interesting. Okay, so my partner, Joe Berkman, talks a lot about this idea of core competencies versus specialized competencies. And generally, in developmental supervision, we start with core competencies, basic therapeutic communication techniques, basic knowledge of what are the mental illnesses, how do they manifest in the lives of the folks we work with, that kind of thing. If you remember from the first presentation, common factors refer to those things that exist in all therapies, like the therapeutic relationship, like trust and authenticity, and those kind of things. And then, of course, we have the specialized competencies, which can involve things like using motivational interviewing, a cognitive behavioral approach, things like that. And it may be beyond us at this point to talk about the specialized competencies, but just to know they're there. So last week, I unleashed this pyramid on you guys, and I admit I don't think it went that well. And this pyramid is really ideally suited for breaking down a specific therapeutic intervention, like motivational interviewing is a good example, or illness management and recovery, or dialectical behavioral therapy, or that kind of cognitive behavioral therapy, whatever it is. But I'm not a quitter, so I'm coming back to it. And so if you think about knowledge, skills, and attitudes as a way to kind of compartmentalize competencies, you can use the same pyramid that we use for our models, and think about that there's knowledge which is compatible but neither necessary nor unique. So you can know things about magnet therapy and squirrels and whatever, and it's completely compatible, but it's not required for the kind of work we do. And then there's knowledge that's essential to what we do, but it's not unique, right? So you really need to know what schizophrenia is and what kind of symptoms a person that's dealing with schizophrenia might experience, and how does it manifest in their life in terms of their decision-making and their choices, that kind of thing. And then depending on your unique field, if you're in permanent supported housing, there are unique and essential areas of knowledge like lease laws and things of that nature, which are absolutely essential for you and unique, that if you're doing vocational work, you likely don't need to know how somebody is evicted and what are the legal consequences of that. So the reason I'm talking about this is in supervision, this approach to reverse engineering the work we do can be really helpful, and it's worth a conversation with the folks we supervise to see if they can wrap their head around aspects of this, and maybe you can simplify it if you want. One person who has written about fidelity a good deal, Gary Bond, he talks about that oftentimes what is prohibited is most important to discuss because it begins to delineate what we should be doing from what we really shouldn't be doing. Like we shouldn't pay out of our own pocket somebody's rent. Seems like a nice thing to do, but it's probably a bad idea. Okay, so lastly, attitudes, and this I admit gets more blurry. You can imagine what a unique and essential attitude is. Just for giggles, put in the chat, what would you say is a unique and essential attitude for the kind of work you guys do? What is a unique and essential attitude? Nice, unconditional positive regard. Carl Rogers, one of my heroes. Housing is a human right. Ooh, ooh, ooh. Be respectful, yeah. Knowledge that change is possible. I might even call that hope, yeah. Belief in positive change and growth. Compassion, yep. I was just thinking about the definition of compassion. A friend of mine uses it's a desire to end the suffering of others, which I think is fantastic. It's great. Yeah, recovery is possible. And you can call that a lot of different things. Hope, yep. Yeah, it's interesting. I work in a psychiatric hospital here in New Jersey, and my office is there. And if you talk about recovery, people really don't believe it. Housing first. Nicely done, Wanda. I once did a poll of psychiatrists. I was doing a training on one thing or another. And I said, give me a thumbs up if you believe that people generally get better over time, people with schizophrenia and severe and persistent mental illness. And give me a thumbs down if you think people generally get worse over time. And some people gave me a different finger altogether, frankly, but the majority gave thumbs down. And these are trained psychiatrists, and presumably licensed. And I realized afterwards that these are folks that see folks at their worst, and they don't see people in permanent supported housing and people being successful in the community. So you should know, yes, that the large majority of people either recover completely or recover in significant ways. It's usually non-linear, so like you see some up and down, but people can have large swaths of substantial recovery in their life, which is really important to know. Okay. So if you weren't here last time, the red line that separates structural from clinical means there are some knowledge issues that might be more turned structural in the sense like how to do the documentation, you know how to get places, how to make things work, and it's not really clinical, but it's really critically important. And then the other side of that line, of course, is clinical, which is knowing the various clinical interventions and strategies. And if you don't know any of those things, authenticity and compassion, that's a good place to start. Absolutely. All right. So breaking down the KSAs a little more. So content or information necessary to successfully accomplish a task. And I acknowledge that there are administrative aspects to this. It's not, as I mentioned, it's not all clinical. But as you might imagine, these are good things to talk about in clinical supervision. just a constant review. You really don't know what your supervisees don't know, right? Unless you kind of walk in there and talk about it. And even if they've been to multiple trainings like I have, it doesn't mean I know something, right? It's just like you guys. You could be asleep right now. I could. I don't think you are, though. I don't think you are. So this, knowledge, knows and understands permanent supported housing principles. There is a fidelity scale, which I'm sure you're aware of, which is a good thing to bring to supervision. I mean, the other way I think about attitudes is we can use the formative function to help form a culture within our organizations, right? We can shape a culture by talking about what values and what attitudes we find important, and how do we utilize those attitudes in our work, and how do they guide us? So the attitude/values, yeah. All right. So knowing and understanding is the knowledge competency. For the skills competency, the idea of skillful proficiency, and I admit to you that this is hard to do in real practice. It's much easier at the university, where we can control a lot more. But the idea of knowing whether someone can perform a certain clinical task is kind of important, particularly as a person wants to go up and become more specialized, if they want to do individual therapy or counseling. In psychiatric rehab, of course, we're using more of those principles, the more kind of generic principles almost, but people can definitely improve in their interactions with the folks they work with. So the skills, the idea of if some people want to move on and get certificates, there's a motivational interviewing competency scale. It's actually a treatment adherence scale called the MIDI. I think it might be the 4th or 5th version right now. And it's pretty anal. I'll tell you, it's like, in order to do well, you really got to kind of walk in lockstep with the theory and the approach of motivational interviewing. And what's cool about that is that scale has been correlated with better outcomes, right? So it's not just that we want to be robots, but there's, if you're doing a lot of active listening and you're reflecting and not talking so much, you tend to get better outcomes. Not always, of course, but I think you know what I'm talking about. All right. So that's the S in KSA. And then lastly, I think we already talked about this in some detail, but personal and social attributes of the person that are necessary for a practice. And I would say values, add values in there as well. Being compassionate, being supportive, being other focused, the belief in, I think you guys didn't use the term hope, but a belief in recovery is certainly a hopeful belief. So this idea then of, and there's a slide coming up at some point that talks about a model of developmental supervision, which is bringing somebody that's relatively new in the field and helping them become a master at doing, not a master's degree, but a real master at doing this kind of work. And feeling like it's meaningful work that they're competent at. It's a great feeling. So how do we do that? So consistent meetings. One of the first things that goes, in my opinion, is clinical supervision. We all get like super busy. And then the other thing, if possible, and this is kind of a pet peeve of mine, but we do want to talk about theory and values and some of the kind of higher level KSAs, and not just about problems, not just about like, Joe did this today and I'm not sure what I'm going to do, and we'll problem solve that. It's important, but we really do want to get to a place where we're talking about the big ideas, and if you remember from last time, the reference standards, like how do we know we're doing a good job? What are we comparing it to? That's a reference standard. One of the best practices in the literature for clinical supervision has to do with a contract with the supervisee. And in that contract, you would identify learning priorities for it, that the person identifies learning priorities, the things that they're interested in getting better at and learning more of. And the idea, just like with the folks we work with, clients, if they choose it, they tend to have higher motivation to take it seriously and pursue it. So that's a recommendation. Very, very few agencies do that. I'm curious, does anyone here do that, where you guys use a supervisory contract or a supervisory agreement? Nice. And Jan, is it a form, like a form that you use for everyone, or is it kind of make it up on the fly? Or Lily? Okay, non-licensed learning license. Yep, yep, yeah. So once you get into the professional disciplines, social work, specific to each person, good. Nice. Yeah, so it's very similar to there's a parallel between when we work with folks, clients, we're doing the same thing. We want to, what's important to them. And I'm sure there's also expectations beyond what they want to do, for the job. That's understandable. Very good. Yeah, once you get into the professional disciplines, and you want to become, like my wife's an LCSW. There might even be more letters there somewhere. I don't know what they would be. But yeah, you need to, it becomes more stringent and regulated, which makes sense. Okay, and then as you'll be hearing today, the idea of our supervisory sessions, we want to have a structure where we at least do mini trainings, or we build in trainings, right, where we supplement the clinical supervision with opportunities for formal opportunities for teaching and learning. One of the neat ideas that I've been doing for the last couple of years is to have people in the supervision present to one another. And there's always the concern, right, that if somebody might not be quite up for that. But in my experience, people take it really seriously, and it's been, on the whole, it's been a good experience. There was a professor years ago, Phyllis Solomon, who, if you read a lot in psych rehab, you'll know the name. But she described a student, they were doing a class projects where the students were presenting to each other. And one of the students said, she was at University of Philadelphia, a very expensive school. And the student said to her, I'm paying like thousands of dollars for this. I don't want to listen to another student. I want to listen to you. And she never did another class project after that. Just really interesting. Okay. I'm not criticizing presenting to one another. I still think it's a good idea. And then lastly, this feedback loop, and we're going to talk, probably make you sick in how much I talk about this feedback loop, but some of the good science about supervision has to do with this feedback loop with a supervisee and a supervisor. So I mentioned this before, but it's worth reviewing this idea of a reference standard being a point of comparison. And you should see these all over the place. There should be administrative standards for paperwork. There are, I know there are. If you have a programmatic fidelity scale, that's a point of comparison. We already talked about organizational values, a point of comparison. And also the professional norms, what's expected of staff. So we would all do well to talk more about what are the reference standards that we're dealing with in our supervisions and in the work we do. All right, so that triangle at the bottom, I don't know if anybody's ever heard of Bloom's taxonomy, but I believe that's Bloom's taxonomy at the bottom. It's maybe the most popular taxonomy in pedagogy, which is the science, I think it's the science of teaching. Pretty sure it's and so in the blue triangle, when kids are in the lower grades, they're just asked to remember the multiplication tables or whatever. It's rote memorization. At least it is in most schools. My daughter went to a Waldorf school, so it wasn't true there. But And then as you go up the pyramid, it becomes increasingly complex, the type of learning that occurs, until the eggheads at the top are doing synthesis and creation and dissertations and that type of thing. So in a similar way, the kind of work we do, you will work with folks, you will likely supervise folks that are unconsciously incompetent, meaning they don't know that they don't know what they don't know. They don't know. They don't know. And so, our job is to help them realize that they don't know, that they're incompetent. And the next step is conscious incompetent, which is you realize, well, I can't do that. You often have people say, I know motivational interviewing, I can do motivational interviewing. I'm like, okay, let's use the MIDI, and why don't you record a session? And I've done that and fell flat on my face because I was unconsciously incompetent, and I quickly became consciously incompetent. The next step is I can do that, and I know I can focus and I can get her done. Now I can at least go through the steps of motivational interviewing. And then you hear this term called unconscious competence, and people like Virginia Satir, who was a group, wrote about groups and studied groups, and she appeared to be unconsciously competent, in the sense that she may not have always known why she was so good at what she did, but she was really good at what she did. So I've worked with a lot of people who were unconsciously competent. The problem was that they weren't always the best teachers, right? Because if you can't describe what you're doing, it's hard to teach it. And also, I think there's another slide here that one of the other dangers with unconscious competence is you may get stuck in a preferred way of providing services, even when it's not appropriate. It's no longer appropriate for some unique reason. It's not the thing to do. I'll tell you a brief story. I was doing work in a psychiatric inpatient unit, and I have a shtick. I don't know if you notice, I have a shtick where I try to be entertaining and clever, and I mean, I'm a hoot. I think I'm a hoot. And I was doing that in this group, and there was a guy next to me, and he just seemed profoundly depressed. He was profoundly depressed. And I'm doing my shtick, and the woman next to me, a therapist, passed me a note, and the note said, "He's going to hit you." And I kind of get this flush of energy as I say that. And what she meant was, now, had he not been so depressed, he likely would have hit me. But thank goodness for me, he didn't have the energy. But without realizing it, I was being invalidating of his experience, right? I was being hopeful and goofy and really disconnected from what was happening in the room and the energy of the room. And so it was an important learning experience that my unconscious competence is not always appropriate to do. So that was a long-winded way of saying we want to get competent, and we want to get meta-competent. What to do, when, why, and then what not to do, what to stop doing, what to exnovate, which is one of my favorite words, because it's the opposite of innovate. And it's my favorite because I'm one of the few people who knows it, apparently. I'm just saying. All right. So we're talking about skills, and particularly clinical skills. And Albert Bandura was the father of social learning theory. And in essence, social learning theory is about how do adults learn in their daily lives. And his thing, social learning theory, is about observation, right? That they can learn, people learn through observation primarily. There's other ways, but that's one of the big ways. And so this comes from Boston University and their skills teaching approach. And it's just memorable because it's tell, show, do, and you probably heard it before. And what it involves is first describing the skill, demonstrating the skill, and then having the person do the skill. So I see somebody has their hand up. Let me go to the chat. If you have your hand up, just write it, post in the chat if you want to make a statement or ask a question. I wonder if my, just gonna check real quick, see if my partner has shown up. Nope, nope. Nope, he has not. Okay, so the idea of tell, show, do, and I think what's critically important is when you, and you can use this with clients, but it also works with staff and ourselves, that the tell, so if I were with you guys and we had the materials, I would give you a bunch of balls so you could juggle 3 balls. Each person would get 3 balls. And I would tell you how to juggle, right? And then I would ask you to juggle, right? And of course you can't, right? It's like I'm going to tell you how to ski, downhill ski. And then I would demonstrate the skill and I'd show you how to juggle. Like it's not a circle, it actually is a cross pattern, right? And still you would not be able to juggle. But then we would practice. And the key here is it's like serving a tennis ball. You don't serve the tennis ball once and talk about it for 45 minutes. You serve the tennis ball 45 times and talk about it for a minute. In other words, it's the performing of the skill with feedback that is the key to social learning. And the same is true. So, you know, you might do rounds where we often use flashcards where we do reflective listening and we just have something to reflect to on the card and we just go round and round and round. And, you know, any way we can think of to tolerate practicing as much as possible. All right. So that's Tell, Show, Do from Boston University. This comes out of a textbook called Social Skills for Schizophrenia. It's an awful textbook name. It's a pretty great textbook. It's Bellack and Musser. And it's wonderful. And it's been pretty well studied. I believe the Lieberman from UCLA, that approach has been studied a bit more than the Bellack and Musser text has. But the idea is clients that we work with often have social skill deficits. It's part and parcel. It's one part of the constellation of issues that comes along with schizophrenia. And so I was teaching out of that textbook, and one of my students noticed something in the margin that the modeling, reinforcement, shaping, overlearning, and generalization spelled Mrs. Ogg. And I never forgot that, and I've never forgotten the 5 principles of social learning theory. And here's the really cool part. Her name was Bartholomew. And spelled the same way that my name is. So what does that tell you? Anyway, this is, if you can remember this idea that people learn if they have a good model, right? And so we can do that with the clinical skills and reinforce, you know, successful movement toward the target behavior, which is really literally what shaping is. And sticking with that, the idea of overlearning is that just keep going, like restorative, formative, normative, restorative, formative, normative. Say it with me, restorative, formative, normative. That's called overlearning, right? Where you just keep going until it burns a path in your brain so you can use it when you need it. Coincidentally, using it when you need it is generalization. Can you take that skill and bring it to this next environment? So if you're in the hospital and you're learning to cook, can you generalize what you learn when you get into your permanent supported housing? I'm sure you come across that constantly. But it's a big challenge of inpatient treatment is this idea of generalization, that it's not particularly helpful if people learn skills that are only useful in the hospital. All right, so that's Mrs. Ogg. That would likely be on the test too, Mrs. Ogg. Okay, so the formative function is our best efforts as supervisors to help people learn new skills, new knowledge, and new attitudes if they need to learn new attitudes. And one of the gold standards is an observation of practice, meaning if a person is, if you're doing supervision based on the self-report of your supervisees, then your supervision is only as good as the self-report of your supervisees, some of which is great. Carl Rogers, the American counselor, who you may have heard of, he's one of the fathers of active listening. He described he did a number of studies on this, the ability of people he was supervising to accurately self-report what they did in a therapeutic session. And he found that early in a people's developmental process, getting into the field, their reports had literally nothing to do with what happened in the session. In other words, they weren't saying they were great and they were horrible, or saying they were horrible and they were great. There just was no relationship. They just weren't aware enough to be able to accurately self-report. So you can see the problem with that, right? Is if that's what we're leaning on to give people feedback, then we're in really serious trouble. All right, but I know what you're thinking. You're thinking, I don't have time to do an observation practice, and I get it. Particularly in your situation, I think many of you work remotely, where you may be in one site and the people you're supervising are going to other sites or apartments, that kind of thing. So there are some proxy suggestions coming up, which meaning what can we do in a session to approximate observation of practice, including role plays and things like that. But that's a second best if you really can't do an observation practice. So what are the options for the formative function for improving staff skills? I mentioned this term mini trainings, and that's just short, almost review trainings about a given approach or a given theory, or maybe even values, attitudes. And then I mentioned proxy indicators, things like role plays, what are called case conceptualizations, where you really talk about, if I look through the lens of the recovery philosophy, how do I see what's happening with George or Harry or whoever we're working with? Case presentations can be good proxy indicators. If you're into behavioral approaches, something like a chain analysis, where you, if there's an event, you look at what happened before the event, what were the kind of triggering issues, that kind of thing. So anybody else have any other proxy suggestions? Because I think we need these, is my sense, particularly with the kind of work you do. I bet you do not have a lot of times where you can see your supervisees. Any other thoughts on proxy strategies for use in supervision? Not everybody at one time. I use the chat there. Proxy. I think the term like a proxy vote, if you're in the Senate, you have somebody vote for you. I think that's what proxy means. I'm not positive. See, I think I stumped you. Yep, case notes, yep. Yeah, good point. Documentation in general is, it's limited, but it's better than nothing. You might, assessments are good. A recovery plan, or, that kind of thing, that would be pretty good as well. Any other? Feedback, nice. Feedback from patients or clients, yep. EHR, nice. Yep, that's a proxy of sorts. Yep. Very good. Looking at outcomes, I mean, that's pretty distal. In other words, it's pretty far away from the staff's behavior, but chart reviews and other from other supervisors, nice. Yep. Yeah, there is something called a 360 evaluation. I don't know if you've ever heard of that, but it's like everyone evaluates everyone else in the circle. And you can look that up. It's kind of cool. I mean, it takes a lot of trust and the vulnerability to do that, but that would be another form of proxy. Because a lot of times other people see folks interacting with clients more than we do. Then there's the self-assessment, which I believe Rogers found that later in a person's career, once they're more versed in the whatever approach they're using, their self-assessments do improve. So that's good to know. Peer review, all of these are a little tricky. We do fidelity assessments, which is a type of observation and practice. It's a little formalized. But we've also had peers do fidelity reviews of one another. If they're running a group, for example, they can do a treatment adherence scale or a fidelity scale. And of course, the more feedback we get, the better. As much, I know it's anxiety producing, but there it is. All right. So I mentioned this earlier, this term audit and feedback. So audit and feedback has been around for quite a long time. And I have a slide coming up where Ivers and a group did a Cochrane analysis looking at, it's a meta-analysis where they take all the studies they can find that have used audit and feedback, and they look at the outcomes, and it's very positive, which I'll show you in a minute. But what is it? So audit and feedback is a process where a person's clinical practice is reviewed or audited by the supervisor and then compared to that reference standard or that professional standard. And it's often can be very formal in the sense like the MIDI, as I mentioned. You can compare the person's work with somebody to the treatment adherence scale called the MIDI for motivational interviewing, and give them really concrete feedback, like you didn't reflect enough before you asked a question, or that kind of thing, or you asked a closed-ended question, or whatever the issue is. And it's in clinical supervision, it's one of the things that has been shown absolutely to change clinical behavior or support change in clinical behavior, including increasing knowledge and skills and the following of professional norms. So let's just look at this. Here's the article. It's a little wonky, but it's worth reading. It's called No More Business as Usual with Audit and Feedback Interventions Towards an Agenda for Reinvigorating Intervention. And this was a review of 141 randomized controlled trials, which is quite impressive because most things don't have more than 1 or 2 or 3 randomized controlled trials, much less 141. Now that's in all fields. It's not just what we do, psychiatric rehabilitation, but there is evidence in psychiatric rehabilitation of its effectiveness. I say that like I know that. Is that true? There probably isn't. Okay, so here's what they found in that article, the meta-analysis. And we're going to review this a little bit, but if you'll get this in some of the materials that I'll send along with not only these tapes, but the PowerPoint slide decks you'll get, and this is in it. And it's really worth looking at, because what it's saying is that audit and feedback works, but it really works best if you do it in a particular way. And so we're just going to review some of the audit components, the feedback components, and the nature of the change required. So when you're thinking about doing an audit, it's best if the standard, the reference standard, as I've been calling it, is an acknowledged criteria for performance. Yes, I'm going to send the handouts. Absolutely, will do. So what does this mean? In other words, it's not Tom's opinion, it's not my preference that you do it this way. There's evidence that if you do it this way, we'll get better outcomes. I mean, that's really the gold standard. Or if the agency requires we do it in a particular way, then that's legitimate too. So the standard is an acknowledged criterion for performance. We call this validity, has validity. It's based on recent performance. So I recently completed a National Institute of Health study, and we used audit and feedback. And unfortunately, the feedback came like a month after, because it took us so long to just get our act together. So that's really critically important. And you can understand why, right? If you're going to make a change, you want it to be on the last serve. If you're going to serve 45 times, you want feedback on each one. All right. And that it's individualized. So it's not about your team. It's something you will have control over. We'll talk about that in a minute. and it's repeated over time. So it's analogous to serving 45 tennis balls and getting feedback that you're going to do it. You're going to get the feedback over and over and over if you can. Frankly, when we've used this, we're lucky if we can get one cycle of feedback. I'm embarrassed to say. All right, so what about the feedback? So best when it's multimodal. So in the study I did, we recorded the session and we gave the person oral and written feedback. So we gave them a written score sheet and then an oral overview of that, including recommendations. Now here's where it gets interesting, right? It comes from a trusted source, meaning you can't be the jerk. You can be, but that audit and feedback works better if it's in a restorative kind of soup bowl where we're out for their best interest, and hopefully this is something they've said they were interested in learning about. It's part of their supervisory agreement we mentioned earlier. So it can't be the bony finger shaking there. It's not that. It comes from a trusted source. And if you have a comparison with current norms, that's also helpful. Kind of lets you know like what's realistic in my setting. In the hospital setting, some of the things we were auditing were really difficult to do in an inpatient setting. And many of the people that I audited did it better than I could do it, which is honestly not saying very much, but they were really, really good at it. So important to note. And then blend of positive feedback as well as corrective feedback. We can overstate this, but this idea of a compliment sandwich, pat, pat, slap, praise, polish, praise. And notice there's no other parentheses. So it's really not a compliment sandwich. Well, yeah. Right, but you want to kind of acknowledge that, yeah, you got this stuff is going really well. Here's an area for improvement. All right, so that's the feedback. The nature of the change. So it's kind of the idea is that if the person receiving the audit and feedback is motivated to change in the direction of the feedback, that's really ideal. And you might imagine they always are, but there are certainly folks within the state hospital system that just don't believe in recovery, and they could receive feedback and disregard it, right? So they just don't believe that patients should make decisions for themselves, that we should take care of them. That's an old idea here in New Jersey, which we've kept alive by just all right. And then the individual or individuals are capable of acting on the feedback. So this is what I referred to earlier. Like it can't be the team. It's not ideal if it's the team that gets the feedback, but it really is best if we audit at the individual level, if possible, not always possible. So that the person can take action and affect the cycle of audit and feedback positively. Okay, so it's getting redundant, but you get the idea. We're doing some overlearning. Oh, this is overlearning. So the target performance or goal is known and provided. So it's one of the reasons I bark a lot about reference standards and talking about them, as if you don't know what the target performance is, it's hard to know if you can't know if you're meeting it or exceeding it or failing to meet it. The goals are aligned with those, ideally with the person's own goals and their supervisory agreement. Ooh, coming up on a break, so hang in there. And that SMART goals are utilized, right? So you can see the overlap between the idea of a supervisory agreement and goal setting and goal achievement. I'm sure you're familiar with SMART goals: specific, measurable, achievable, relevant time. And then lastly, a clear action plan is then provided. So the feedback is something the person can take action on, and it's very specific and measurable. And so you think about this whole process as a series of feedback loops where we set, define, identify those reference standards. The staff then performs. They either run a group, or they have a session, or they do what they're doing. and then they receive feedback from the supervisor. And this can happen at all different levels. It doesn't have to be a therapy session, because I know a lot of your folks don't do therapy sessions exactly. And then you either see change or not, and you can problem solve, what got in the way. And it's all of this is in a supportive, intended to be done in a supportive medium of, the restorative function of clinical supervision. All right, so that is audit and feedback. Anything that's, whenever you see capitalized letters, this is Joe Berkman, this is my colleague, because this is how he types, I don't know why. But he's talking about doing it frequently, doing it face-to-face, encourage staff to take control of what they can, make it a high priority, and be realistic. I think very good advice, a good summation. So the science of audit and feedback tells us that it works best when the gap between the performance and the standard is greatest, right? So if you're working with Sigmund Freud, good luck using audit and feedback, because the guy's amazing. And probably hard to, or that guy. Not sure who that is. I suspect he's very good though, if I picked his picture. All right, so just like anything else, clinical supervision suffers from the finding the time to do it, as well as, if you need a direct observation of practice, that can be really, really challenging for you guys, for any supervisor, particularly if you supervise a lot of different people. And so even if you get an audit and feedback cycle in, it's hard to do it regularly, and nobody gets reimbursed for supervision or for audit and feedback for that matter. This one is also a big deal, which is, do we have enough valid tools in psychiatric rehabilitation to offer valid feedback, or, or do we have to kind of default onto more generic feedback, which is fine too, but it's really helpful if you have valid tools, as mentioned in the review earlier. And then, just like in the state psychiatric hospital, oftentimes things do need to be adapted. It's just the nature of the beast. So that's audit and feedback. So if you guys thinking about this audit and feedback, can you imagine a way to use it, or what you would use it on if you were going to use it in your setting? What do you think? How much you use audit and feedback? I'll bet you're going to say some administrative things like the treatment plan has to be done in this way, which is absolutely fine. I mean, that is a legitimate use of audit and feedback. But what do you guys think? Put it in the chat. How much you use audit and feedback in the work, or how do you use it if you're currently using it? Hey, and it's almost cookie time. We're going to take a break. All right, no takers for audit and feedback. There it is. We use it regularly when counseling from, my chat is cut off. When counselors return from being activated to contact tracing, nice, yep. Clinical work again, and being gone for months, nice. Yeah, during COVID, holy smokes, absolutely. We have weekly meetings and monthly case reviews, yep. Yeah, so you can use the same process with those proxy activities. That's absolutely true, and it's probably more realistic for the kind of work you're doing. But just so you know, we've got the gold standard out there. All right, so here are these awesome references. I'm going to read you these microscopic references. No, I'm not. All right, let's take, what do you think? How much time should we take? 5 minutes or 10 minutes or an hour? Should we take an hour? But no, let's take 5 minutes. Go to the bathroom, and maybe we'll get out early. Woo! Take 5, and I'll meet you back here, and we'll start part 2. All right. I think I went a little longer than 5 minutes. A couple of people had their hand up, and I figured out how to make talking permitted. So if Jeanne, Sarah, or Classroom wants to say anything or ask a question or make a statement, you're welcome to. I did bring a banana because I was going to do a banana joke, but I got my PhD last year and I can't do this anymore. Try and live up to the hype. All right. So yeah, unfortunately, my handler, the fellow that was going to work the chat box, didn't show up, which is fantastic because I'm going to really lord that over him for quite a long time. But if you, yeah, so put your hand up. If you, I'll unmute you if I can do it as I rub my belly in my head. So at this point, we're going to move on from the formative function to the last of the 3 functions of clinical supervision. And I think of these 3 functions as like, what are we trying to accomplish when we do clinical supervision? Well, we're trying to do these 3 things. We're trying to be restorative, formative, and normative. And we got to fill in those boxes with, strategies to do each of those 3 things. And there's no right answer, as I mentioned earlier, right? It's what works for you, what works for your team, what works for your unique agency, Okay, so this last function, the normative function, remember it's restorative, formative, and normative are the 3 functions. And the objectives for this last topic are understanding the tension between accountability and psychological safety. I know last week somebody made the point, well, can't you have accountability and psychological safety? And yes, of course you can. But if you've ever done a termination for cause, it gets difficult and it's tense, and there is clearly a possibility for tension in that relationship. And then, so we're going to explore that a little bit to address the issues of administrative and clinical issues within supervision. These are terrible objectives, by the way. You'll see why. So I'm curious if people have had specific training in offering performance feedback or doing performance evaluations. Do people receive training in that, or is that something you kind of sink or swim? What do you think? Anybody receive training? Oh, I see that on groups, give feedback. Yep, we'll send the hands, yep. Interesting, yep. A little bit from HR, no training. That's me, Gloria. I'm with you. I remember the first time I taught a class, I was a chapter ahead of my students. Sorry, I had no, yeah. That was rough. All right. So, I mean, one of the things we're going to be talking about then is the idea of evaluation in clinical supervision, which you've been dancing around it a bit with audit and feedback and whatnot. And I'm just disabling here. So this definition comes from Derek Milne, and I presented it in the last Monday. And he talks about clinical supervision as the formal provision by approved supervisor, poof, that's you guys, of a relationship-based education and training. It's work-focused, manages, supports, here it is, and develops and evaluates the work of colleagues. And this evaluation piece is what distinguishes it, according to Milne, from coaching and mentoring, which often don't have the formal evaluation piece. They have a feedback piece, of course, but often don't have a formal evaluation piece. So I mentioned, I put this slide in because I realized that my academic focus and one of my interests is on what is called intervention-specific supervision, which is supervising a particular clinical intervention. But I suspect that you guys likely do more of this, which is developmental supervision, where you constantly have new folks coming in and you need to orient them and prepare them for a life within the field, or at least as long as they choose to stay in the field. And so this is one of the more common developmental models of clinical supervision. It's called the Integrated Development Model, or IDM. And it looks at the relationship of anxiety to evaluation and fearfulness about evaluation at the first level, which is really common, of course. Level 2, supervisors are at mid-level and experience fluctuating confidence and motivation, often linking their own mood to the success of clients. So they're still maybe overly, what's the term, projecting, and I don't know if you even want to call it professional distance, because I hate that term. I'm not even sure what exactly it's supposed to mean. But they're really kind of very closely linked with their success and that of the clients. And then the third level, according to this model, that supervisors are essentially secure, stable in motivation. This is all you guys, if you were supervisees, and have accurate empathy tempered by objectivity and the use of therapeutic self and interventions and evidence-based interventions. So that idea of objectivity is the mindfulness or the reflective practice that I was referring to earlier, that once we've been doing this kind of work long enough, and if we've gotten good feedback and good supervision, we can begin to internalize that. Somebody called it an observing ego, where you can kind of have a more accurate assessment of what you're doing and what you're good at, what you're not so good at. All right, so that's just for your edification. So the normative function, sometimes called the administrative function, but it's more than that, is an alignment of the supervisees with professional and organizational reference standards, ethics, and norms, right? So it is an accountability function. I consider it also like an accountability to using the best evidence when possible, when it's available, to determine what to do. I think I used last week that, if somebody went out to an apartment to support a resident there and was using primal scream therapy, that might not be the best choice. Maybe it is, but it may not be. I use that example because a psychologist at one of the psychiatric hospitals, in fact, did just that. They had somebody screaming, and had the psychologist warned everyone that that was the plan, that would have been helpful, because it was very disruptive. I don't mean to pick on primal scream therapy. I don't know anything about it. Could have good evidence. All right, we saw this in the previous set of slides. But here again, in the normative function, we see the same need for reference standards as a point of comparison. And it's never more true than in the administrative areas, where, what time are you supposed to be here? What's the paperwork supposed to look like? What are those expectations? How do you fill out your timesheet? How do you fill out your transportation reimbursement, whatever? All of which are effectively reference standards that, if a person does the job well, they got to know how to do that stuff. And again, this is a bit redundant, but the idea that one of the reference standards is absolutely the mutually agreed upon professional goals. And I would argue that when somebody gets hired, they're agreeing to the standards of practice of that agency, right? That's that they're entering into an agreement. You'll pay me if I do these things in these ways, or within that confidence interval between, there's a little wiggle room, but. So the normative function uses the same type of feedback loop as the formative function. It just generally in the area more so administrative, but also norms and ethics, that kind of thing. Okay, so what are the tools of the normative function? Like, how do you do it? Primarily, you read in the literature about performance feedback and performance evaluation. And performance feedback should be happening constantly. That's the feedback loop that should occur over and over and over. A daily activity, getting various forms of feedback. Usually, performance feedback is verbal, but there are opportunities to write it. I write it when somebody does a really terrific job with something. I really make a point of writing it, and you'd be surprised how influential that is with your supervisees. Of course, one danger is, if you do it for someone, and someone else does something great, you want to do that. And so, but I'd rather err on the side of missing some opportunities than missing them all. So, as mentioned, it can be formal or informal. And in my opinion, the performance feedback can really help shape that organizational culture that I keep mentioning. I worked for an organization, it was called the Clubhouse. It was called The Club, but it was a Clubhouse model program. And it just had mission magic. In my opinion, I was of the age where that was really important to me. And that was shaped through not just performance feedback, but a lot of feedback about the philosophy of the program and the values of the program. And to this day, it was one of the best professional experiences of my life. Largely because of the type of feedback I got. Okay, and then the other tool is the more formal performance evaluation. And this is always written, all right? And it can have verbal components, but you really gotta write this down. It's a pretty serious part of the feedback from the organization, from the supervisor to the supervisee. And we generally do this at scheduled interviews, and you know this already. I have a yearly performance evaluation, which is all I have. And honestly, I never hear anything about it year to year. Right? So it just comes up and I don't even remember what the goals were. So I would not do that. Do as I say, not as I do. And I'm not doing it. It's Rutgers University does it. So one of the dangers about the idea of feedback and evaluation is that it's got a bad rap. Right? That, and I take this back. It's not that nobody wants to be supervised or evaluated. Some people do. And some people really enjoy supervision and leadership. I can't say that I aspire to leadership, but I can imagine some people do. But it can raise a lot of anxiety, the idea of giving somebody feedback and doing their evaluation. Particularly, I think in a lot of small agencies, the supervisor rises up through the ranks, and so they may come to supervise their peers, and that dual relationship can be really tricky, as I suspect many of you know. I was out there a few years ago, out in Washington State, in I'm going to say it wrong again, Wenatchee, and one of the people in the training said that they were peers, and then they became supervisors, and he was peers with a friend that he used to go fishing with, and was a good friend. And he decided he couldn't go fishing with them anymore because it would be too much of a dual relationship, which is quite sad. Friends are hard to find, and but I appreciated and respected his decision to do that. Okay, so I mentioned this before. This caught me. This quote, but it's the idea that a tension exists in clinical supervision between the need for psychological safety, which is the essence of the restorative function, right? We want to take care of one another and be supportive. And to do that, it's helpful to have, as much psychological safety as possible. And at the same time, we have to hold people accountable for being effective at their job and showing up on time and paperwork. And good supervisors get this balance right, or mostly right, but it's a struggle. It can be a struggle. And this was, I think, Tony Butterworth, who writes about clinical supervision, used this term, a tyranny of niceness, which is the idea that, and I must admit, I suffer from this tyranny of niceness, meaning that I want to be liked by my supervisees, and really everyone, frankly, but But that hurts me, and I become a tyrant in the sense that I don't give the feedback people need in a timely way, and it hurts me as a supervisor, and it hurts them as a supervisee. And when I do that, or when anyone does that, we can leave inexperienced people without direction, and let people stray too far from the desired performance. Whoops. And inadvertently betray both the employees and the consumers. So I believe this, right? And I'm just curious, anyone else want to share and do we have any other people that was, oh, I got it, woohoo! See that? Wanachi. Well, Wanachi. I'm gonna stop there while I'm ahead. Is anyone out there would care to share? Are there any tyrants out there that suffer from the tyranny of niceness, where you want to be nice and it impacts on your ability to be the best supervisor you can be? I'm going to turn on Betsy's. Well, she's raising her hand to say she's a tyrant.
Hi.
Are you a tyrant?
Well, yeah, it's just Midwest nice. You know, you just want to be active in cheerleading, and sometimes there's things that need to get said, and it's hard to do that in a cheerleading sort of way sometimes.
Is Midwest nice? Is that a real thing?
I think so.
Yeah. You know, I've done some terrible trainings out there, and everyone just says I'm great, and they're just so sweet. So that's great. Anyone else want to share? Allow all these folks to talk. The classroom can talk. I actually think this is a bigger problem in supervision than when I first read about tyranny and niceness. I related 100%. Said, yeah, that's, especially if you got into this field to be a helper and you're empathetic and compassionate. I think we can fall prey. All right. So the major purpose of feedback and evaluation, this is the chair of my department I stole this slide from, and he talks about it as, really we're all there to fulfill the organization's mission. That's why the organization exists. And I would add, like, and to be kind to one another and compassionate. But yeah, there's some truth to this, right? It is about the organizational mission. And we want to encourage behaviors that do that and discourage behaviors that don't do that. And particularly when they're really far away from what the mission is calling for, these are areas that need attention. And so we want to shape behaviors through corrective feedback and promote a reflective practice. As I mentioned, in the world of developmental supervision, eventually people will build in this reflection, this reflective practice loop, where they can be more self-governing, you might say. They call that a cybernetic loop, right? Which is a self-correcting machine, or a where the machine gets enough feedback where it can, I know it's getting kind of wonky, but staff can do the same thing. And those feedback loops, that comparing staff performance to reference standards is a big part of the type of performance feedback we need to give, as I've been saying. I know I'm beating a dead horse, but and then when we document performance feedback, performance evaluation, what we're trying to do is inform promotion and merit increases and discipline if necessary, or termination. Anyone that's ever gone through a termination, particularly a difficult one, knows the importance of documentation. And we'll talk about it. And I know this is kind of not the sexiest of topical areas, but it's really important. If you ever get into a situation where you need to fire someone, terminate someone, it's really important that you've thought about this and that you do your best to follow the HR policy. So I think many of us can reflect back on our careers in this field and remember important feedback that was well delivered, sometimes not even well delivered, but that it really is the kindest thing, and it can shape our trajectory in this type of work in really important ways. The getting the note that says that he's going to hit you, that was really important feedback for me. And then when I reflected on it, I realized, like, kind of what a jerk I, no, just unconsciously, because I was just so unaware at the time. But I've had many types of feedback like that, some more painful than others. All right. So in doing performance feedback and performance evaluation, corrective feedback needs to be private. We don't want to hang people out in group supervision or in the hallway or whatever. And that we may want to document that, and particularly if it's becoming a pattern, because if things do require termination at some point, we need the documentation so it's not your word against someone else's word. If you're giving positive feedback, it's absolutely fine to do it privately and publicly. During COVID, I'm doing a lot of Zoom sessions, and I make a real effort to sing people's praises when they're doing good work. Generally speaking, we want persons should hear things verbally before they receive it in writing, particularly if it's some kind of corrective feedback. Unless, of course, like if somebody makes a huge error or really kind of screws up, then written feedback maybe is the first thing they hear. And I know we beat this the idea of pat pat slap, but delivering mixed feedback is ideal. So anyone that's been a supervisor for a long time knows that, particularly as we're circling issues like termination or discipline, you often get a poor reaction. And some of the ideas, not to provoke it, but be ready for it. In other words, you can't expect that, somebody that's receiving feedback that might result in their losing of their means, their job. It's pretty stressful and can be quite upsetting, obviously. So what are some typical reactions? You've probably seen these. It's very common for folks to be defensive, everyone else does it, or I didn't do it. You see hostility and sullenness, sometimes ready acquiescence or over-agreeableness, apologizing and crying. I know I'm bringing you down, especially after the awesome formative session there, but so uses of feedback and evaluation. This gets pretty complicated. For many years of my life, I worked with folks who were recovering folks with severe mental illness. We called them prosumers, where they were professional consumers. It's probably a terrible term, but and even in that role, we had to be very careful that we were not there to do treatment. We were not there to rehabilitate the staff, even when they're prosumers, and particularly when they're not prosumers, less reason to do that. But we are there to help support them to contribute to the mission. And frankly, if someone needs too much help, it may mean that we refer them to personal counseling or the HR employee assistance programs, if you have. I suspect many of you are from relatively small agencies that don't have your own internal, but you may have a referral source. Maybe they need to be counseled out of this line of work, or in the more extreme cases, they may need to be fired, let go. Okay, so this is another slide I stole from the chair to my department. And in your role as supervisor, he recommends avoiding excessive agnosticism. And if you're not familiar with that term, an agnostic is someone who doesn't believe either way, and that often used in terms of religious belief, or they're unsure either way, and so they're kind of in the middle. And so when he says excessive agnosticism, which is like, I don't know, And he recommends brainstorming with the person to enumerate as many possibilities for dealing with whatever it is they're bringing you, and as many possible outcomes. And I agree with the second line quite a bit, that you don't want to be too prescriptive, particularly when you're really time pressured. There can be a danger of just trying to solve the problems, and because you can unwittingly not have all the information and end up giving the wrong advice. And so I really like the brainstorming and encouraging the person to make an informed decision best they can, when that's practical. So trying to avoid resentments, because remember, part of what this is about is the sticky thing about the tension between psychological safety and accountability. And so avoiding resentments, one thing is, timely feedback. So you don't want it to be too hot, like, oh my God, I can't believe you just did, did that. But maybe let it cool a little bit, but not so much that it's so down the road that it doesn't seem pertinent to the person anymore. As a supervisor, you don't want to bend more than you think you should. You want to be agreeable and supportive and accommodating when possible, but there's got to be limits. Reasonable accommodations only. Of course, there's the formal reasonable accommodation, which is the federal a federal guideline, but there's also reasonable accommodations for just people's lives, become tumult, and they often need unique support, and you got to play it by ear to some degrees, but it's got to be reasonable and uniform as much as possible. So here's where I think this gets interesting. This idea of consulting with your own supervisor for instrumental support or emotional support. Many times people attending this particular training are supervisors, but you're kind of in a sandwich between a leadership, an administration, and supervisees. And my experience is you can often get squished. Either the organization is telling you to do things you don't completely believe in, or they make decisions that you weren't a part of, and you have to sell it. You don't want to become complicit with your supervisees and be like, oh, they're a bunch of jerks, and that's a recipe for disaster. But you also, you're stuck with, maybe you have to deliver a message that isn't your message. I think that often happens. But nonetheless, many of you often do have supervisors you can reach out to for support, and I would recommend you do that. This is something I highly recommend you consider, which is developing a peer network of supervisors, so that you don't look to your subordinates for support, and you may, it may relieve you from seeking support from administration, who has a very different agenda perhaps than you do. So I think there's more on this peer network. We did a pretty sophisticated peer network here in my work. And so what we did, let me just see if I included that, maybe at the very end. But we did a peer network where we have a supervising session for supervisors, and the focus of the supervision is on best practice. You guessed it, supervision, right? So that's the reference standard, is like how to be a good supervisor, and you can bring supervisory issues. And the feedback has been extraordinary, with people that have been doing this work for a long time saying this is one of the best professional experiences I have, because they're caught in the middle and they're able to kind of unpack things that they don't feel comfortable unpacking with their supervisor, and they certainly don't feel that they can talk about to their subordinates. This can also form a sense of healthy competitiveness. So my group, they started talking about observation of practice, and that became a competition, like who can actually pull it off, because it's so hard. And we focus on instrumental and emotional support in that group. And I must say, I'm not currently supervising anyone. I supervise programs, but not people. But I find that meeting extremely supportive and helpful. The other option for a value of a peer network are professional organizations. Like here, we have, there's a national organization called IASPERA, and each state has a chapter, and you may be familiar. What's your chapter's name? Does anybody know? If you could put it in the chat. Here it's NJPRA, so it's the New Jersey Psychiatric Rehabilitation Association. So I'll bet you have the Washington Psychiatric Rehabilitation Association. Is that true? Does anyone know? But that's a terrific organization, and you'll meet other supervisors there, and even if joining that organization, becoming part of the conferences, it's absolutely great. If you're into this kind of work, I would highly recommend it. Or are there other professional organizations that you guys are involved with? Is anyone involved with any professional organization? Like the NASW or, oh, there you go. We work with NIAPers. That's the New York. Oh, they're great. Yeah, there's some ACA, the American Counselor Association. Yeah, oh. Cool. Yeah, that's right. I bet a lot of folks are more in the LCSW or the LPC, the Licensed Professional Counselors, or MSWs, or yeah. Cool. Yeah, so I would consider that if you haven't thought about it. All right. So just like in fact, I think this is very similar to the previous slide in the formative function, but the feedback is the same. It's the same issue, right? It's being as clear as possible about reference standards, being consistent, and making sure everybody understands what the expectation is as clearly as possible. All right, so moving on to the performance evaluation, that actually annual or semi-annual time we meet with each person. And I know I'm not telling you anything you don't already know, but this is an opportunity to articulate the goals and what are the standards, and to do that supervisory contract if your agency uses it or if you choose to use it. There will be a generic supervisory agreement in the information I send you. I'm going to send you like 8 or 9 documents. The professional agreement is actually in the first document, and so you'll see there are 3 things in the first document. They're just all in one big file. But I encourage you to check that out. It's comes right out of the literature. So another slide I stole from the chair of my department. He believes everyone, even volunteers and board members, should get a performance evaluation. It's really an opportunity for that big feedback loop to occur. And it should be designed specifically for whoever is receiving the evaluation, whatever that job description is. If you have a driver or a maintenance person or whatever, of course, the evaluation is specific to the work they do. The worst thing these performance evaluations can become is once-only feedback, which, as I already mentioned, that's in my experience, it is really a once and done kind of thing. That shouldn't happen. So as I mentioned, the research is quite strong that mutually agreed upon goals, whether it's our clients or our supervisees, really does have an effect on the motivation of the person setting the goal. But what's critically important, just like if we do a treatment plan, if we never refer to it again, it has little, there's really no sense in doing it if you're not going to refer to it. And so this idea of then the supervision, ongoing supervision, would be evaluating those goals over time and try to keep them alive. And in my experience, a person can set restorative goals. There's nothing wrong with that, including, are there some self-care issues that I really want to work on because I can't do this job unless I take care of myself. Interestingly, those are some of the most common goals in the supervisor supervision, where people set restorative goals because, they're wearing themselves out and they know they're going to burn out if they don't change something. And so they try to change something. They get out and walk at lunch. They leave on time more often than not, that kind of thing. And of course, go for the SMART goals. Okay, so the evaluation, this is nothing, hopefully it's all a review. But it is really an opportunity for dialogue and to take the time to really think about what goals are important to the person, what are the agency's expectations, and that kind of thing. And it should reinforce what you've been talking about all along, about what we're looking for. And it's, if nothing else, it is a source of documentation. So we had somebody was terminated from one of the hospitals, and they had just glowing performance evaluations, and then they were terminated. And of course, that's a big problem, right? Where every indication, every piece of documentation said one thing, and then the supervisor said something else. So don't want that to happen. And it is a reinforcement. So I'm surprised these aren't capitals, because this is Joe Berkman. It should be capitalized, all this stuff. I think if there's any mistake that I've seen supervisors make, it's not preparing well enough and really thinking through what it is you want to cover and what it is you want to say. And I know your jobs are super time pressured, but this is often really important to the supervisee. And so we want to give it the time it requires. If you're giving some specific feedback about concerns, you want to have thought about what kind of remediation would be helpful, and see what's been getting in the way. You know, let's just have a conversation about a remediation plan and what would, you know, what would help. So I'll let you read these. I know you can read. Go through each rating completely. My wife often receives, you know, they send it to her. They say, look it over, sign it if you agree. There's really no conversation at all. These are not the standards we were shooting for. All right. Don't threaten or be defensive. Make it safe. Yep. And make it future-based. Nice. So, you know, I find performance evaluations cumbersome, and you know, my fear is that I haven't talked enough about it in supervision before the evaluation comes, and then the person can feel blindsided if there are issues. When there are issues, there should be some critical feedback, right? Nobody's perfect. They're often not specific enough, so you know, the good job thing, not enough, or you need to improve, not enough. And then I don't know if you remember from the first session last Monday, but this idea of supervision concerns that people can, you know, we were having a pretty good supportive relationship, and now the person realizes that all this time I've been watching them and waiting for this evaluation. One of the worst experiences that I've had is that there was a time where I had to rank order staff. It was something the university thought was a good idea. And so everyone cannot be exceptional, right? And so you had to kind of put people in a rank order. And that was, as you might imagine, that was difficult. And, you know, I think it's possible for a lot of people to do a very good job. And it seemed kind of arbitrary, frankly. So the common mistakes, we already covered many of these, but you know, when the performance evaluation is the only feedback tool, that's a big problem. Don't use enough. We don't spend enough time preparing. This is where you really want to prevent a tyranny of niceness and poor prep, non-alignment of goals or remediation plans. Yep. All right, so if you're using when you're using performance evaluation, you know of a good job, you know you've done a good job if the person knows to what degree they've met expectations, they have an area where they can work on, right? Because we want to, everyone's, you know, trying to move towards a better place, including the supervisors. And we've identified a major strength that can contribute to the organization. I think that's terrific and very hopeful. So special considerations, if you're working with somebody who's in recovery from a severe and persistent mental illness, I mentioned the term prosumer. I don't know if that's the national term or just something in the East Coast. But if you're a consumer yourself, do not confuse your viewpoints. This is actually very common. My department has done a good bit of research in what are the issues that affect folks in recovery that are doing this kind of work. And one of them is this projection of their experience onto the people they're supervising, which is a no-no regardless if you're in recovery or not. Don't be too hard or too easy. There was this interesting article that said that people in recovery can be harder on other people, right? Because they kind of climb their way up, and it's kind of a rite of passage, so that can be a problem. So if you're the supervisor for somebody in recovery, you do want to take the illness into account, but not let it become an excuse, right? So just like everyone has issues. Those issues might be related to an illness, but it can't become an excuse. We have to have the same standards. I don't know if this is Patricia Deegan who had the soft bigotry of low expectations. I'm not sure where that came from. But that's pretty important if in the world of supervision of folks in recovery, that oftentimes you set the expectation and people rise to meet it, right? That's the point. And then encouraging the person to have a relapse plan. What is the person going to do to take care of themselves in the event? I mean, it's just like managing any illness. You want to think about what if and what's the plan. So I think that's really good advice. All right. So my favorite topic, employee termination. I can't stress this enough, but really know your agency's policies on progressive discipline and termination. You just hear the horror stories. There was a woman who that I was supervising who just had all of these issues, and by the time it became clear that I had to terminate her for the sake of the people she was working with, as well as her peers, the other workers, the union swept in, or the union she was involved with swept in, and kind of the whole process started over. And unfortunately, it became quite the saga. But so had I known the agency's policies and been more focused on that, it would have been really helpful. So you want to, if you have a human resource department, if you don't, you may want to seek out, who can help you understand this, including your supervisor or the leadership of the agency. So, as mentioned, you can't say this enough, follow the policies meticulously, and documenting according to the letter. I did not do this so well. It was not my main focus, and I didn't know that it would come to a head the way it did. And so had I kept notes and been more organized, it really would have been helpful. And of course, there's different types of terminations depending on your agency. And one is called for cause, which is the person has done something that maybe they took somebody's medication or something pretty crazy, or not for cause. So in the university world, we can just not be reappointed. So they're just not reappointing us. There's no cause, they don't have to say or do anything. You fill out your term of appointment, and that's it. So that's a not for cause type of situation. And then, of course, you can go on conditional or probationary status in many organizations. But you should learn about these if your organization has these as policies, procedures. They're important. All right. So I don't have as much time as I thought. I was hoping to. Any questions on any of this mumbo jumbo that I've been peddling? I am going to, I mentioned another topic which I prepared, and I'm just going to tell you just a little bit about it because it's fascinating. And I want you to get your money's worth. But this is a topic that I'm very, very interested in. It has to do with implementation theory, which is how do you implement something within an organization and increase the chances that it's going to be taken up and used. And the reason this is important is there's evidence that about 75% of implementation efforts usually to use evidence-based practices, but it can be other organizational changes, fail to accomplish their mission or fail to do anything at all. In other words, they fail completely. And so it's a monumental waste of time. And there's a science has evolved to address that called implementation science, and it's the implementation theory. And see, I put it as the fifth topic. Dun, 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 dun. But I'll offer if what's her first name? Castle. If she's interested, we can do a session on implementation theory if it's something you'd like to learn more about. But I won't belabor you with the whole thing. But what it's about is what are the best strategies? What are the best practices in the use of, boy, this is very familiar. In the use of implementation science. And as you can see, I'm showing off a little bit here, but that Bartholomew, and that bolded Bartholomew is me, working in the, publishing in the area of implementation science. And there's, I've been learning over the last year or so some strategies that really help. And the way it relates to clinical supervision, here's the hook, is clinical supervision can be used in the implementation as a tool of implementation, or you can implement clinical supervision using the same strategies. And the thing I really wanted to show you, here's the science to practice gap is something that is a big problem in our field, where we know what the science of behavior change is, and we know that some strategies that would really help, and they're hard to get into practice. But I'm going to skip all this. I just want to run down to, So here's a diagram of that, what we call meta supervision, where the top gray box is a meeting of supervisors. And then each of those supervisors supervises a different program. And it has worked extremely well. And I encourage you to think about this strategy. If your organization is composed this way, it might be something to consider to set up a supervision for supervisors, even if they're doing different things, because there's enough commonalities, I think. So I'm going to leave it there. Kimberly Castle, thank you. Thank you, Wanda. That was embarrassing. I actually know Kimberly pretty well. Yes, I'm going to send the slides from this training, and also there's about 10 documents. I'm going to send you a burnout scale, a whole bunch of organizational commitment scales. On the off chance you want to look at your organization and through those lenses, those are normed scales. So the burnout scale, for example, we'd compare your organization to nationally people in mental health. And I'll send you a supervisory contract. I'm going to send you a clinical supervision fidelity scale, which we didn't really talk much about, which has a lot of these ideas, and it's used to measure supervision. And you can just look at it and see kind of how you're doing. All right. So that's about all I've got. Any final thoughts before we sign up? You guys were the best crowd I had all day. Yes, thank you, Shri. And I'm very impressed. I got to send that $10,000 check to the person who got the Kingdom of Saudi Arabia. That was a good get. You're the only one ever to get that, by the way. Are you from the Kingdom of Saudi Arabia? Is that how you knew that? Or because that was very expensive. Oh, great. Thank you, classroom. Thank you, thank you. Yes, I've stolen this material from everyone. And I'm not above stealing stuff from you. If only I could hear you. Thank you so much. Thanks. All right, guys, we're going to leave it at that. I'm going to stop the recording. Unless you want to say other nice things about me, which I'll leave the recording on. Thanks.